Dear colleagues, let me thank the organizer for the kind invitation, and now I'm in the presentation with this important topic, left atrial appendage occlusion, updates and clinical structural interventions. Okay, when we talk about left atrial appendage occlusion, we have to consider that in the setting of atrial thrombosis, we have to consider that anticoagulants provide systemic protections from thromboembolism in all the arterial circulation, whereas obviously the device can stop only the thrombosis in the left atrial appendage. And in valvular atrial fibrillation, the thrombus is located in the LAA in only 10% of, in only 40% of this situation, whereas in the non-valvular atrial fibrillation, 90% of thrombus is located in left atrial appendage. Then obviously these interventions is reserved for patients with non-valvular atrial fibrillation. These are the first studies considering patients, a randomized study with, in comparison with warfarin anticoagulant, and they showed the significant reduction in hemorrhagic stroke, whereas the cause death was similar, and major bleeding non-procedure related also were decreased with left atrial appendage occlusion, but obviously we were in the warfarin era. These are a result of a multi-center Italian registry, 613 patients with high CHA2DS2 and high ASBLED as well, and we have a low rate of ischemic stroke and major bleeding lower than expected on the basis of the CHA2DS2 score. This is a major issue after the procedure. You can see the device-related thrombosis. His rate is described between 3 and 5%, and obviously can be a favorable outcome. This obviously the therapy after the procedure can protect from thrombosis until there's a endothelialization of the atrial appendage. And the first studies in comparing the anticoagulants versus the procedure used anticoagulant for the first 45 days, followed by the APT for 3 and 6 months, whereas in the ACP amulet device, the studies considered the APT only between 1 and 6 months. But today the situation is different because every device uses the APT for 6 months, 1 year. And this is a prediction of device-related thrombosis is the question. There are specific factors, age, female sex, history of stroke, high CHA2DS2, non-paroxysmal atrial fibrillation, hypercoagulable disorder, chronic kidney disease, and some parameters echocardiographic. And obviously the procedural factors, deep implant, large device size, and obviously iatrogenic pericardial effusion and exposed metal screw in the device surface. This is a review of Professor Calabrò, and on behalf of the Italian Society of Interventional Cardiology, and obviously they showed that there are bleedings, events, and device-related thrombosis. So we have to navigate into these two shield and carry situation. But which is some issues today, the indication of the procedure. Main indication is contraindication of anticoagulants, and obviously now we are in the DOAC settings, and then we have not to consider anymore the warfarin studies. These are obviously the trend of stroke, atrial fibrillation related. This is a Swedish registry. You can see that the ischemic stroke are obviously decreasing, but not the hemorrhagic stroke. Therefore, the bleeding complications of anticoagulants are still issues. And in this registry, many patients with a high AS-BLED score obviously didn't take anticoagulation at all. Therefore, we have this result, obviously these studies, comparing in anticoagulant against procedure, and you can see that the latest studies, PREG-17, and we spoke about afterwards, but obviously DOAC are many limitations. Patients with mechanical heart valves, with rheumatic valve disease, antiphospholipid syndrome, high gastrointestinal bleeding risk, and also patients undergoing TAVI. These DOAC were not tested in renal insufficiency, impaired liver function, and obviously patients with low body weight. This is PREG-17 comparing procedure LAA closure against NOAC, mainly apixaban in high-risk atrial fibrillation. CHA2DS score 4.7 and AS-BLED 3.0. And obviously the results are very good. This is non-inferiority of procedure against anticoagulants with less bleeding complication. This trial has some limitation, underpower for individual endpoints, non-inferiority margins, not data available on DOAC adherence, and crossover from patients from procedure to DOAC therapy. These are the ongoing studies on LAA closure, modern, obviously, situation with DOAC in the medical therapy arm. There are obviously ongoing, but the option trial was recently published online on New England Journal of Medicine and presented at European Congress recently. And the option showed that in the device was not inferior to in comparison with the anticoagulant after ablation of the atrial fibrillation in terms of efficacy, but it was superior in terms of non-bleedings, both measured bleeding at very important bleeding. Obviously, also the study has some limitation, but showed that after ablation, the procedure can be considered. Other studies are ongoing, I told before, and Champion AF, we participated with our center, and the enrollment is over. We are waiting for the results in next year. You can see that the therapy after the procedure was very heterogeneous. In this ASAP2, the no therapy versus SAPT, other trials are very variable, and they considered both SAPT and anticoagulant. Techniques, these are two techniques. The most most known procedure is obviously endocardiac with transseptal puncture and implantation in the left atrial appendage in the left atrium, and there are another technique both inside the heart and outside with the ligation of the left atrial appendage. This is practiced in very selected centers, therefore the widespread technique is the endocardiac procedure. And there are two studies comparing the two devices most used in the world. This Amulet Eye, 1,800 patients receiving Amulet versus Watchman. The Watchman is the first version, and there are similar results. But procedural complications are more frequent in the Amulet arm, whereas the successful implantation was more evident with Amulet device. These are the ESC guidelines, recent ESC guidelines, and the American Heart Association guidelines, and some differences because in the ESC guidelines, European guidelines, the procedure is, can be considered in patients with the contraindication for long-term anticoagulation therapy, whereas the American guidelines considered patients with the contraindication, but also for alternative to anticoagulation after discussing with the patient, obviously, the indication. The reservoir indication are child vasc more than 2 and high gastrointestinal bleeding risk with anticoagulation therapy like severe gastrointestinal bleeding or bowel angiodysplasia, very low renal function, and hematologic disorders. Can be considered as also previous hemorrhagic intracranial hemorrhages and with irreversible causes, non-modifiable risk factors, and the need for concomitant antiplatelet therapy like after coronary PCI, embolic event while in anticoagulant therapy, and also patients with not compliant with anticoagulation therapy. Thank you very much for your attention.